Good morning, dear friends, respected chairman, dear colleagues. My topic on percutaneous wire fixation of fractures of the patella, a unique non-invasive technique. Percutaneous anklage wiring for patella fracture can be applied through several small skin incisions without dissecting the fractured region and surrounding soft tissue and provides a minimally invasive approach to this procedure. We all know the conventional methods of treatment for fractured patella: open reduction, internal fixation by K-wire, tension band wires, CCC, depending upon the fracture. As in all the fractures, in patella also mini invasive approach to reduction and fixation of fractures of the patella, intact or partly injured quadriceps tendon we have advocated and performed in many cases. Out of 21 cases, 13 males, 8 females, and mean age being 53 years. The indications for percutaneous wiring are undisplaced or cracked fractures of the patella, minimally displaced fractures which can be easily reduced and fixed, displaced of the fractures of the patella which can be easily reduced and quadriceps mechanism is intact or partially injured clinically, comminuted fractures of the patella with fragments in situ or easily conglomerated fragments which can be fixed by this technique. These are the various type of fractures and pictures which can be fixed by percutaneous wiring. This is a technique. From one end we start percutaneous wiring under C-arm control and clinical picture, and we pass both encirclage wire as well as figure of 8 wire under C-arm. The main problem is the puckering of the skin, which should be properly released, and wire should be straightened, tightened so as to encircle the patella fracture fragments. In grossly displaced fractures with complete rupture of quadriceps expansion, which require quadriceps repair, are not suitable for this technique. Also, compound fracture of the patella with injury to the quadriceps mechanism, also open reduction is indicated. This is the surgical technique in brief. Fracture is evaluated clinically, C-arm control, extent and type of the fracture pattern, status of the extensor mechanism, hemarthrosis is aspirated to decompress the joint. There are 4 portals for passing the wire. Wire passed using wire passer. Twist should be avoided by proper pulling, and puckering of the skin should be avoided by proper undermining of the wires subcutaneously. Seesaw motion with every passage of the wire through portals to allow smooth passage of the wire is very essential. In all cases were fixed by encirclage wire number 18 fixation and 1 figure of 8 fixation. Interestingly, after passing the wires and gradual tightening helped in reduction, alignment and approximation and compression of the fracture fragments which can be seen under C-arm control. No K-wires were used for fixation. Reduction and fixation of the fracture and articular alignment was confirmed under C-arm in all cases in extension as well as in full flexion to ensure the stability of the fixation. Quadriceps expansion needs no repair. Percutaneous suture without K-wire internal fixation with the principle of tension band wiring is adequate for all these cases. There is some difficulty in twisting of the wire while passing and puckering the skin at concerned incisions. Twist in the wire can be prevented by keeping enough length of the wire and go on untwisting it while passing. Maneuvering and thus twisting of wire can be tackled at 4 corners of the patella, and puckering of the skin can be avoided by undermining and dissecting the running soft tissue caught under the wire so as to release the skin. These are some of the examples before operation and after fixation. This is one case. This is another case. You can see the reduction, alignment of the fracture fragments. Since it does not involve the dissection through quadriceps muscle and aponeurosis, it saves the extra surgical time so as to split and repair the muscle. Since the muscle is not disturbed, The rehabilitation of the knee is easier, better, earlier as compared to open technique fixation. Passing of the wires and gradual tightening helped in reduction, alignment, approximation, and compression of the fracture fragments. To describe more advantages, range of movement training can be started early after surgery because the soft tissues are included in wire fixation. In comminuted fracture cases, an early stage of range of motion training may facilitate indirect reduction through 3-point bending forces loaded on the patellofemoral joint in flexion and extension of the knee joint, even if the patellofemoral joint surface cannot be accurately reduced. We suggest that percutaneous osteosynthesis, which includes stabilization of the soft tissues but performed without extensive dissection, is more appropriate for severely comminuted fractures. The scar is cosmetic, less painful, and less stiffness as compared to conventional fixation. Still one more case, percutaneous wiring, figure of 8 and encirclage wire, and you can see the alignment. Complications of open reduction and internal fixation include knee joint contracture, particularly in extension, as adhesions between the quadriceps femoris muscle and femur at the proximal patella are implicated. Since no dissection is applied to the soft tissues in this procedure, adhesions causing post-operative contracture are unlikely to occur. For simple two-part patella fracture, it is possible that osteosynthesis with the screws or classic tension band wiring obtains better fixation, but in cases of comminuted fractures, this method can be difficult. For these reasons, the method of percutaneous encirclage wiring, including the soft tissues around the fractured patella, is an effective alternative. Moreover, even if some minor irregularity of the articular surface of the patella remains, the early commencement of range of motion exercises after surgery may cater for remolding within the femoral groove. All fractures healed uneventfully. The mean Linsom 2 score was 84.8. All the patient range full range of motion within 6 to 7 weeks. A mean quadriceps atrophy of 0.8 cm compared with the contralateral side was seen in unilateral cases. There was no implant failure or infection. 2 swelling and occasional discharge at the wire node, which subsided after removal of the wire after the fracture is united. All fractures healed uneventfully. These are some of the cases with full range of movement. This is the picture showing the very small healed scar which cannot be detected after percutaneous wiring the patella. Patient can sit cross-legged. Active SLR is possible. This is the technique where fracture fragments can be held percutaneously with the patellar clamp. Another case with a minimally displaced fracture, post-operative after fixation. One more case, X-ray and post result picture of patient squatting and sitting cross-legged. You can see the union at the end of the 8 weeks. One more case, pre-operative and post-operative X-ray. These are the follow-up clinical photographs at 2 weeks after removal of the sutures. You cannot see the puncture wounds. To conclude, percutaneous close reduction and fixation by stainless steel wire is appropriate for undisplaced, minimally displaced transverse fracture patella without major separation and comminution, longitudinal or oblique fractures. Even if there are more than 2 major fragments are amenable to this technique, providing the fragments are large enough to be fixed with wires. The technique is minimally invasive, does not disturb the vascular supply of the patella. It allows clear visualization of the reduction and stability of the fracture under C-arm control and facilitates early post-operative range of motion exercises. This method is also suitable for highly comminuted fractures or transverse fractures with minor separation that are not accompanied by rupture of the extensor mechanism. This technique provides good mini-invasive for reduction, fixation of the undisplaced, minimally displaced comminuted fractures of the patella with intact or partly injured quadriceps expansion, helps early recovery, rehabilitation and regaining range of movements better, faster, easier for patients operated by this approach as compared to those by conventional. Thank you all for your kind listening.